Okay. Good morning, friends. Welcome back to Saturday Club of Baroda meeting. And today we have with us Dr. Dhrumil Patel, who is a very eminent orthopedic surgeon, has been giving talks to Saturday Club of Baroda in past also. And he is a very well-known orthopedic surgeon of Baroda, young, dynamic person, and he has done fellowship at various places. And his special areas of interest are sports medicine, joint reconstruction, etc. So, Dhrumil, welcome back to Saturday Club of Baroda.
Thank
And you have about 40-45 minutes to talk, and we'll keep 10 minutes for discussion. So, over to you.
Okay. So can you see my screen, sir, or no?
Yes, we are able to see your screen.
Okay, fine. So good morning, everyone. Thank you so much for the invite. I thought to make it more interesting, let us have a case-based discussion on various advances that we have in the joint surgery these days. So the next 40 minutes will be mostly case-based, and then we will discuss out the routine questions if at all anyone has. So first is a hip joint. We all know what a hip looks like, and so this is a 22-year male. He has pain in both the hip joints, and you can see with my arrow. You can see my arrow over here.
Yes.
Yeah, so the hip joint is incongruent. There is pain, stiffness, both sides. He's a patient who had history of COVID. So this is avascular necrosis of both the hip joints. So when you have a patient who has avascular necrosis of both the hip joints, the main problem that the patients have is pain in the hip, antalgic gait, not able to walk for long distances, pain even in the night when they sleep. So I'm sure you can see the video, right?
Yes.
So these are the patients who come to us who have restricted rotations at the hip joint. So when you rotate their hip joint, they will have restricted rotation. Most important thing is loss of movement. They are not able to get up from bed and walk long distances. So then what is the treatment? I think in 2025, treatment for avascular necrosis is not medicines, it is not rehab, it is not core decompression where you used to drill holes in the hip and put stem cells. It is not a hemi hip. Because the joint is incongruent, the treatment is total hip replacement. So he has been operated for a bilateral single sitting total hip replacement that you can see. That's the cup, that's the ball, and that's the stem, which will provide him great movement. So we do a direct anterior hip replacement these days. And the advantage of doing a direct anterior hip replacement is muscle preserving surgery. It can do surgery on both sides. So that is a patient second day post surgery. So that is a patient who is walking on his feet without the walker, with a bilateral total hip replacement, which is done on the same day. So that is the advantage that we have. Technology is there to help us do a surgery very precisely. We have great implants which are there, and these implants help patients recover really fast. Within 6 weeks, they get back to their normal activity. So going up and down the stairs also becomes easy post surgery. Is the same patient who is able to sit cross-legged, who is able to go up and down the stairs. So it is very easy for the patient to carry out his daily activities. He's a 22-year-old male. Don't forget about it. He's a very young patient. He's a long life to live. And he has been operated for a bilateral total hip. And he's able to resume all his activities with a preserving approach, a muscle preserving approach. So direct anterior hip replacement in 2025 is the standard of care, wherein you preserve all the muscles. You go in from the front. Conventionally, we used to go from side or from behind. That is called a lateral or a posterior approach. Now we go for an anterior approach, wherein that's the surgery wherein you go in, you preserve all the muscles which are there. So that's the tensor fascia lata in the front, and then you remove the hip joint. So that's the ball which is removed, and then that's the cup which is put in, and then that's the stem which is inserted with a muscle preserving approach. All the muscles here, of course, are preserved. The most important thing that you can achieve with this is good limb length. So when you're doing a surgery with an anterior approach in a supine position, you can balance the hip to the other side and replicate the three-dimensional anatomy that the hip has. So I think that is the key to doing a hip replacement surgery these days. So direct anterior approach, muscle preserving, is easier for the patient, faster rehab, good patient satisfaction. You can do surgeries on both sides together. You don't need to do an interval surgery like doing on one side and then doing the other side after 6 months. You don't need to do that. And you have better limb length advantage. You can better achieve the limb length of the patient by doing a direct anterior. Another case, he's a 51-year-old male. He's a domestic fall fall at home, and that's a fracture neck of femur. Now, his 51 patients are still active. He's a prominent jeweler in our town, and he has been operated for a total hip replacement the next day, and that is how his recovery is. So he is able to walk with a walker the same day. He's a 51-year-old with all the cardiac problems that he has. He's on blood thinners. So he's able to walk, put weight, and now he's able to sit down at 6 weeks. So after 4 to 6 weeks, we allow them full restoration of movement. They can do what all they want to. They can go around. They can sit cross-legged. They can walk, climb up and down the stairs, everything. So that is the advantage. That is the era that we are in right now. Even for major surgery like a hip replacement in the past, these days, the recovery is around 4 to 6 weeks with all the muscle preserving approaches that we have. So he is a 51-year-old. Remember, he drives a scooter, he drives a car. So we don't need to restrict him with anything when we have a surgery is in our hands. So that is the key. What about infection in hip surgery? Well, a lot of patients are worried about infections. He's a 33-year-old male who has pain in the left hip. He has been operated for a hemiarthroplasty in the past 5 years back. He's a patient with chronic kidney disease. He's on dialysis. He has weak bones. So what has happened here is the ball has migrated into the pelvis because of the infection. So that's the infection that the patient has. That's the hip joint. The capsule is open, and that's all the pus that is draining out. So these days, you don't need to worry about infection if you know what is the organism. We have a lot of good tests with which you can identify what organism there is, and then you put an antibiotic-coated cement spacer for a young patient, and then give him a revision hip on which he can walk again. So the infection now is cured after a proper debridement and a second sit surgery on which he can bear full weight and carry out all his activities. He is a singer. He's a folk singer in our state, and he carries out all his programs without any problem. So infection is also not a problem these days. We don't worry much about it. The most important thing for joint infection is that we need to identify what organism is causing the infection. Also, one thing that I want to add on infection is we are always worried about surgeons. So people or the patients have the perception that the infection has occurred only because they have undergone a surgery in a certain hospital. Infection is mostly from the patient. It is from the normal organisms in the body that we have, which is causing the infection. So we guide our patients that infection is from their body and it is not surgery induced. So that is important. So that is about hip. The reason why I wanted to talk about replacement in hip is that we have an audience who is the average age is more than 50, I think, for the audience that we have today. So I will be talking more about joint replacement, a little bit about joint preservation. So this is knee now. That's a young patient, 56-year-old, medial osteoarthritis, medial compartment osteoarthritis, as you can see on the arrow. The lateral compartment is still preserved. The osteoarthritis that you see on the lateral side is more on the anterior aspect. The posterior part is preserved, and the patellofemoral articulation looks relatively okay. So this patient has only MJL pain, means only medial joint line pain. He has good range of motion. His passive range of motion at the knee joint is absolutely full, is absolutely fine. His main problem is he has pain while he's walking, so he's not able to walk. He doesn't feel like walking. So he's a 56-year-old. Well, in this era, you don't, you don't resort to a total knee replacement for all patients. And so when you see the long leg alignment axis film for the patient, he is in varus, not excessive varus. So when you have a patient like this, you can definitely offer them a partial knee surgery wherein you only restore the medial side which was affected. The other sides, the cruciate ligaments that the patient has, the lateral collaterals, the medial collaterals, the patellofemoral joint, and the lateral compartment, everything is normal. So you don't replace that. You don't resurface that. We have only resurfaced the medial part which the patient was having pain at. And that has given them excellent range of motion. So that again is a 48-year-old, another patient operated for a partial knee, one side. And the best thing about doing a minimally invasive surgery is that the patients are able to get good range of motion. So you're able to see that the patient, I think there is some lag in the video. I'm really sorry about it, but then I'm sure you're able to see what I'm trying to show you. So the patient get good range of motion at 4 to 6 weeks, and they're able to easily carry out their activities and sit cross-legged by doing just a partial knee surgery. The most important thing is this is more like a natural knee. Their cruciate ligaments are preserved, their collateral ligaments are preserved, and everything that they are doing is on a natural knee with just a medial spacer which is there. So that is a partial knee. The biggest advantage of a partial knee for a relatively young patient is that they always have a chance to undergo a total knee replacement after 15 years if they want to. The average age for a partial knee replacement surgery is around 15 to 20 years. It can last like a normal knee if you have good BMI control. So that is about partial knee replacement. There's another case who is 63-year-old now. She's relatively old than the other patient, and then she has pain on both sides. Her range of motion is restricted. So she has fixed flexion deformity of 10 degrees to 100 degrees. The normal range of motion at knee joint is from 0 to 135 degrees. Average range of motion is. And this patient has a stiff knee with more affection of also the anterior compartment of the knee joint, the patellofemoral compartment. And when you have a patient like this, wherein your alignment is in varus and you have a medial plus anterior patellofemoral compartment disease, then you can straight away go for a total knee, wherein you also change the anterior compartment, which is the patellofemoral side. And these patients also recover really well. These days, we do a muscle preserving, robotic assisted or technologically assisted knee replacement surgery, wherein we don't cut any muscle. And so the alignment that the patient has is like your natural alignment. So this patient's alignment before surgery was some degree of varus. You can put that knee even after surgery in that much controlled varus using technology assisted surgery. The most important reason why you want to put them in their constitutional varus is because they have been living on this varus. They've been walking with this varus for almost 63 years of their life. Most of us, they do have some amount of varus in our knee joint. So when you make their knees from bent to straight, they will not like their knees. What they really like is their natural constitutional varus post a knee replacement surgery. So that is what technology helps us with. You can control the amount of correction that is to be done in their limbs, and you can replicate a one-sided performed surgery to the other side. So if this surgery was done, suppose 3 months back, and then you want to restore the same thing on the other side, you can calculate the amount of varus that the patient has and can do that on the right side. So they will feel their limbs are similar. The feel of the knee is similar. So that's the patient before surgery. She is walking with varus. Now, the most important thing is these knees are bent from 63 years, almost 63 years. She has tight knees, and this is the same patient 8 weeks post-recovery, post-surgery. So now she has regained her range of motion at the knee joint that she had. The most important thing is restoration of strength, because muscles are not damaged while you are doing a technology assisted surgery. So they have good quadriceps strength. So going up and down the stairs becomes easier. Going up from the bed becomes easier. And they again are walking with the varus that they like. It is a constitutional varus that the patient likes post surgery. So remember, you don't want to make your knees straight. The most important thing is you need to restore the natural native anatomy that you had. So in 2025, we always want to restore the anatomy that the patient had. What about wound closure? Well, when we're doing a total knee surgery, lot of times there has been confusion about the sutures. Most of the time, this is 4th-generation wound closure. So that's the arthrotomy that has been done for the knee replacement surgery. These are the exposed bones. Now, once you put the implant, you again want to close the wound in the same layer. So we again restore the synovium, which is there over the component. So you don't have irritation of the tendon when you are doing your exercises. And then your capsular closure these days is with barbed sutures. It is not the normal Vicryl PDS that we used to use. The capsular sutures are the barbed sutures. I'm going to talk about it in a second. So that's the intermittent suture that we put to the capsule, and then we restore it with continuous barbed suture, which is called Stratafix. This antibiotic coated suture, where there is just one tab at the bottom, and then you pass sutures like a continuous layer. So it is like a zip line suture, like you close a zip. You don't need to tie knots on it. It is barbed suture, means there are barbs on it which are unidirectional. So you will not lose your muscle strength. You will have relatively less pain when you're doing the early physiotherapy in the first 4 to 6 weeks. And these sutures, they are completely absorbable at 3 months. So that is the biggest advantage. You will get your strength back. You will get less pain when you're doing the physiotherapy. You don't need to tie knots every time. It is relatively quick than doing those conventional stitches. So you have less chances of infection because there is less tissue damage because of the knot. You again inject tranexamic acid into the joint after the perfect wound closure. So these wound closures these days are watertight. So you have less leaks from your wound. That is the most important part of the surgery. I think patients are always afraid the blood that comes out from sometimes from their dressing while doing the physiotherapy, they're always afraid. And I think that we really need to work on our wound closure. The dressings that we apply these days are also completely biodegradable. This is a polyester mesh which is applied, which is covered with cyanoacrylate glue. So there is a skin glue over which you can have a bath. It is completely water repellent. So it is easy to have a bath post surgery. And you can also carry out your excessive exercises that you want to twice a day with less tension on the soft tissues that has been approximated. So I think wound closure these days is relatively easy. So that's the patient whom I have operated for one side, and this is with the advanced wound closure techniques that we do. This is just 4 weeks post surgery. He has recovered only 60%, but still see the scarring is also different on both sides. So advanced wound closure is something I think which is again very important these days. When you talk about knee, you always need to talk about infection. Any joint infection is a problem. So this is a patient, 67-year-old. She has been operated for a knee replacement surgery 8 months back, and she has pain, swelling, warmth in the knee joint with increased CRP, ESR. The main problem that the patient has is there is infection which is inside the joint. This infection has also reached the bone, so there is osteomyelitis. Now, this infection cannot be cured with oral antibiotics or IV antibiotics. You need to go in for an infection like this and remove the collection which is there, send it for culture, identify the organism, and then do a two-stage surgery for this patient. So when you're doing a two-stage surgery, most of the time you put a cement spacer. So this is an antibiotic coated cement spacer which has been put in the knee joint. The biggest advantage of this spacer is even with the spacer inside, you can carry out some degrees of range of motion and can walk on it with partial weight bearing. So you're not completely crippled for the 6 weeks during which you have your cement spacer. You are able to bend your knee, you are able to walk on it, go to the washroom, use the bathroom whenever you want to with a walker with partial weight bearing on it, and then come for a revision surgery after 3 months or 6 weeks whenever your organism is under control, when the infection is under control. So this is a patient which has been operated for a revision surgery because of infection, and revision again is possible. It is very easy these days. So this is the patient who has restored her knee range of motion even after 3 surgeries. First one was, of course, the primary knee that was done, which was infected. Then she was operated for a cement spacer, which was the second surgery. And then this is the third surgery, which we have done on this patient. And remember, these are older patients. These are 63, 67, average 70 years. She's also able to climb stairs with relative ease. So this is the important thing about the surgery. When we do advanced techniques while doing the surgery, they are able to gain their range of motion. They're able to gain their gait patterns really well, even post a revision surgery. So that was about infection. We need not worry in 2025 about infection. I think there are enough data to suggest that infection comes from the patient. Remember, it is not always from the surgeon. We have organisms in our nose, we have organisms in our mouth, we have organisms in our gastrointestinal tract, even the genitourinary tract. So these are the organisms which we need to control, which we need to optimize before surgery. We have also organisms in the skin. So most of the time it is the skin organisms which are causing infection. So very important that infection comes from the patient. Remember, it is not always surgeon induced, and we need to treat it well. We need to keep the patient in mind and tell them what they need for their infection. Now I'm going to talk a little bit about shoulder. This is about various joints. So when you have an audience wherein the average age is more than 50, I would want to talk about rotator cuff tears, which is very common. Every shoulder pain that you have is not frozen shoulder. Remember, when you have pain with weakness, it is mostly the rotator cuff muscle which is torn inside your shoulder. So in shoulder, there are actually 2 floors. This is the ground floor, which is the glenohumeral joint, the joint which is responsible for the tight capsule and frozen shoulder. And then you have the subacromial joint, which is the top floor, the first floor, wherein you have problems with the acromion, clavicle, which is arthritis. And the other problem is because of impingement, the acromion hitting on the humeral head while you are doing overhead activities. That is when your rotator cuff gets degenerated and eventually torn. So that's a patient wherein she's almost 72 years old and she has pain and weakness. She has been treated for frozen shoulder for almost 1 year. Now, she's not able to lift up her arm with relative ease. The main problem that she has here is weakness of the muscles. And if you don't test these muscles, you will never realize what she has. So it is the torn rotator cuff because of which she has pain and weakness. She is not able to restore her shoulder activities. She is not able to comb her hair, not able to sleep on the same side. So it is night pain which is bothering her, not able to lift up utensils from the top shelf of the kitchen. So these are the things that the patients have. And when you have a patient like this, I think X-ray will tell you limited stuff. Most important thing is to do an MRI and see where the rotator cuff torn is. So that's the torn rotator cuff. Again, another patient, left side is affected, not able to lift up the arm. These days, again, we do a technologically assisted muscle repair. So this is the patient for which we have done a shoulder arthroscopy. Now we go into the shoulder and remove all the blood which is there, all the frozen shoulder which is there, and that's the torn cuff, the muscle tear which you see. What is to be done here is that you put various anchors inside your bone and then pass sutures through your rotator cuff muscle and then put it back on the bone. So that's a double row rotator cuff repair for the patient, wherein we have restored the anatomy which was lacking with this patient. So these are relatively old patients. Remember, they come to us with frozen shoulder, but they don't have frozen shoulder. They actually have a rotator cuff tear. We restore their muscle and we restore their movement. So another patient with a rotator cuff repair post-surgery, when you do it in repair, do the repair in time that the patient needs, and when you put them on a good rehab protocol, most of the time, they will be able to restore their activities. This is another patient with a domestic fall. So she just has a small, trivial fall, a jerk injury in her shoulder, and she comes to us. She's diabetic. She's a 58-year-old female, and she comes to us with a fracture like this. That's the proximal humerus fracture, which is almost 6-part. 1, 2, 3, 4, 5, and 6. So there are 6 pieces of her humeral head. And she's diabetic. Remember, the most important thing that we do in 2025 is not only repair the fracture, but also repair the rotator cuff back to the muscle, back to the plate. So you restore the soft tissue balance which the patient requires. So that's the same patient for which we have done a proximal humerus fixation, but it is the strength is restored because she has been treated also for the rotator cuff which was torn. So these are postmenopausal females and they come to us with pain in the shoulder. Most of the time, it is the rotator cuff which is affected. So even in fracture scenario, rotator cuff muscle repair is very, very important. This is another 60-year-old female in which we have done a hemi replacement, but we have also repaired the tuberosity, the greater tuberosity where the rotator cuff inserts. We have repaired it to the processes. So it is, I think, it is the repair of the muscle which gives them good movement in the shoulder. If we don't put it back to the processes on itself is not going to act. So restoring the anatomy, very, very important. Soft tissue preservation and repair of the soft tissue back to the processes that is there. So very, very, very important. This 82-year-old male, he has arthritis in the shoulder. So there is glenohumeral shoulder arthritis, treated for frozen shoulder for such a long time. And then he comes to us with 6 months of history of unbearable pain, not able to sleep, sleepless nights. Now, the main problem here is rotator cuff arthropathy. The rotator cuff is gone. There is arthritis, treated for frozen shoulder. We have done just a reverse shoulder replacement for him. What you do in a reverse shoulder is you change the ball and the socket in such a way that the ball goes inside and the socket comes outside. So that is called a reverse shoulder replacement. I think this is the operation of the century for shoulder because this makes your rehab so easy. You put your rotator cuff muscles back to a reverse shoulder, and he's an 82-year-old patient who has been able to get almost 90% of his activities he's able to do with his right shoulder, which was not functional for almost 3 years, remember. So even when the patients come in a chronic situation, we are able to restore most of their movements. I think the main reason is that we have realized that it is the soft tissues which are helping the surgery. These surgeries, the joint surgeries, are soft tissue surgeries. These are not bony surgeries anymore. We don't overtreat the bone. We just resurface the bone with the implant that is needed and then restore the soft tissue around it. Another patient operated for a reverse shoulder on the left side. He is 67 years old and he's been able to restore his activities. I think the reason, as I told you, is the rotator cuff. So when you have an old age patient, when you have a patient who has pain in the shoulder which is referred to the neck, it is not always cervical spondylosis. Sometimes it can be the weakness of the rotator cuff which is causing you the neck pain. So remember, clinical examination of the patient is the key. I don't give opinions on WhatsApp. I don't treat patients on online appointments. I think it is most important to see the patient live and then do the x-rays which are needed for the patient, and then do further investigations like CT scan or MRI if it is needed. Little bit about foot and ankle, because the age group that we are dealing with today, the Saturday Club, they do have heel pain or pain on the back side of the heel. It is mostly the retrocalcaneal spur which is causing you the pain. The most important thing is that patients are not able to use their footwear. So it is the back side of the shoe which impinges with this bony spur which causes them pain. And the reason why that they have pain is because of the tight tendo Achilles. So the calf muscles are tight, and you always test your calf muscles. Remember, it is a tightness in the calf which is causing you the pain over here. So there was a time when we used to open up the back side of the heel and then remove the spur and then put the tendo Achilles, the degenerated tendo Achilles, debride it and put it back with suture anchors on the bone. The biggest problem with this technique is that it is on the back side of the heel, which has precarious blood supply. So sometimes there are wound healing issues, and you delay the rehab of the patients because of wound healing issues. These days, we don't worry about the open procedures. These are minimally invasive techniques that we adopt these days. We do an osteotomy, which is called a ZX osteotomy. We relieve the tension on the tendo Achilles by changing the calcaneal height by doing an osteotomy of 8 to 9 millimeters on the back side of the heel. We close this osteotomy and fix screws so that you relieve the tension on the back side of the heel, the tendo Achilles. So the only one way that you can relieve the tension on the back side of the heel is by doing an osteotomy. So that's the patient who has been operated for the back side of the heel. We have done surgical marking on that, and then with almost a minimally invasive technique, by using a small precision burr with water irrigation, we have been able to remove bone with just a small 1 to 2 centimeter incision from the backside of the heel. So we are removing cutting bone with a small incision. So respecting soft tissues, preserving their native anatomy, and then removing that bony wedge of almost 8 to 9 millimeters and relieving the tension on the tendo Achilles by closing this osteotomy. So now this osteotomy is closed by doing dorsiflexion of the ankle. We remove the bony spur with a burr again with small incisions. And now once the spur is out, the osteotomy is done. We fix this with headless screws. These are the screws which are almost 6.5 millimeter, but they're headless. They don't have heads. They go inside the bone. So you won't feel the screws when you're wearing your footwear. So this is what it is. Small incision surgery on the back side of the heel, wherein you remove the spur, but you also correct the anatomy that the patient has. You try to restore their anatomy, relieve the tension on the tendo Achilles, the backside of the heel, by doing a ZX osteotomy. So very, very important foot and ankle surgeries. Again, another condition, relatively older patients, they come with hallux valgus. So they have heel problems, and then they have forefoot problems wherein the great toe causes pain. So it is hallux valgus. You measure their angles and it is hallux valgus. Traditionally, we used to do an open surgery. Not anymore. Again, we can use the same burr that I talked about and remove the bony spur, do an osteotomy again, and correct the bony alignment that the patient has. So the bony alignment now is corrected. The forefoot, the midfoot are in proper orientation, and fix them with multiple screws. Of course, even the phalanx here needs correction. So with the jig, we have put screws, and the phalanx has been restored with a small osteotomy in the proximal phalanx. So the biggest advantage of doing a minimally invasive surgery these days is that you are able to use small incisions. With burrs, you're able to remove the bony spurs that the patient feels. And this is a patient who is going to weight bear post-surgery the next day. So you allow early weight bearing because you have preserved all their soft tissues. With small incisions, you can get faster recovery. So this is the same patient, 2 days post-surgery, they've come for a dressing, but again, a small dressing and almost less swelling, almost no swelling in the forefoot by a small minimally invasive surgery. These are the patients who are able to resume their office activities very fast post-surgery. So almost 4 to 6 weeks, they are almost able to resume almost 80% of their activities at office. So that is the advantage of minimally invasive surgery. I think with this, we come to the last segment, wrist and hand, which is again very common. A lot of patients, they come to us with tingling and numbness. It's a 30-year-old female who has tingling numbness, carpal tunnel syndrome. We are all aware what carpal tunnel is. The main problem with carpal tunnel is that there is compression of the median nerve at the carpal tunnel. And we used to do traditionally a lot of open procedures. Nowadays, we do it endoscopically, minimally invasive again, put a small incision at the wrist flexion crease, and then beneath the subcutaneous tissue, you have the carpal tunnel. Put a guide under it, and then under direct vision of the arthroscope. So that's the fascia that you see at the top. That's the carpal tunnel fascia, which is there. The median nerve is beneath the cannula. So you can just release it with an endo knife like this. Straight away, a 5-minute procedure, less than 5-minute procedure. You release the fascia under direct vision, so you don't damage the median nerve. And then once you are completely released the fascia, you rotate the cannula, and the median nerve is below your cannula. So you've always protected the median nerve in the cannula. You restored the blood supply which is needed for the median nerve, and it is just a small 1 centimeter or a 2 centimeter incision with which you can do a carpal tunnel and again resume your activities very, very quickly. The scar, of course, is less, so swelling is less. For the first 6 weeks, of course, we give them a little bit of exercises. And once the circulation of the median nerve starts, you are able to recover with your routine activities. So small dressings, minimally invasive surgery, less pain, faster recovery. A lot of patients, they come to us with distal radius fractures. And she's a 51-year-old lady with a left side fall on outstretched hand, push injury. She's left hand dominant. She does all her activities on the left side, and she has a bad intra-articular fracture of the distal radius. I think what is really important these days is not only fix the fracture, but also you see that the ulna is hitting the carpus. It means the ligament of the distal radial ulnar joint is also damaged. So these days we do technology assisted fixation of the fractures. We have gone into the wrist joint, removed all the blood. That's the TFCC ligament, and that's the torn ligament which is there. We have repaired the ligament back to the bone, arthroscopically assisted. That's the scope that goes in. And then we have fixed the fracture with a minimally thin, minimal invasive plate, and they restore their activities completely. So very, very important. We have restored their distal radial ulnar joint. We have fixed the TFCC ligament arthroscopically and also fix the fracture. So these are the patients, when you restore their anatomy, the strength of the fracture post-surgery, that comes from the muscle and not only from your bone. So we these days respect the soft tissues. It is very, very important to do the surgery accurately. So this is the last slide for today. Take homes from me for recent advances in joint surgery are that joint surgery is far advanced than what you think it was 20 years back. These days, you see this patient, she has been operated 4 times, and then I have done a 5th revision hip for her. And you can see she is 78 years old, but still able to walk on her hip with all the implant that she has. So we have reconstructed the acetabulum, we have reconstructed the proximal femur fracture, and on a hip replacement like this, she is able to walk. This is an 84-year-old female for which we have done a reverse shoulder replacement on the right side that you see the image. And she is able to do all her activities on her own even at 84 years of age. So that is really important to understand that joint surgery these days is very much advanced. Knee replacement surgery, though you think is very common, the poor results of the knee replacement surgery are because of lack of respect to the soft tissues, I think. So we as surgeons have realized that respecting the soft tissues and then restoring the anatomy really helps. So joint replacement surgery these days is relatively easy for the patients. When you talk about other surgeries, mostly they are minimally invasive, only because it has easier rehab, less pain to the patients. So most of the other surgeries are either done arthroscopically assisted, means you put the scope inside the joint, or endoscopically assisted, it means you put the scope inside the soft tissues which are there around the joint. So minimally invasive really helps patients who are in the younger age group. These days we do give less antibiotics. As I told you, infection comes from the patient. So what is really important is to optimize the host while they are undergoing a surgery. So adequate amount of turmeric, adequate amount of warm milk, adequate amount of curd is what is really important while you are undergoing a knee or a hip replacement surgery. Milk, turmeric will help you with your immunity, with your oral throat organisms. And when you talk about curd, it is going to really help you with your gastrointestinal organisms. So these are the basic things that we advise our patients. We don't give them much antibiotics. Most of them are discharged the next day of surgery. When you talk about diet, I think post-menopausal osteoporosis or post-hormone reduced osteoporosis is a reality in our population these days. and we give them a lot of calcium, vitamin D rich diet. We advise them gentle exercises. Yoga, pranayam helps with flexibility, and gentle weight bearing and strengthening exercises, which should be once or twice a week, not more than that, because it is going to keep your bones strong. We as surgeons, as I told you, are striving hard to make things even easier and better for our patients. So we always will be on our toes to make things better for you. Thank you.
Thank you, Drumil. You can stop the screen sharing. Wonderful, as was expected, no? Brand, higher brand, I would say. Quick fire overview of so many conditions that you were treated. And the base part of your talk was that it was all full of beautiful illustrations, how well the patients recover. So that was wonderful journey. And now we know what are the advances which are happening in the field of joint surgery. So now the house is open for discussion. Any comments, questions? Today our Jagdish Bhai is not there. He is in USA, not able to attend.
Okay.
Usually he starts the ball rolling with questions. Hemant, you have some questions? Because he is a surgeon amongst the audience.
Yes.
Okay, so it seems there are no more comments or questions. So we close the session here. Thank you very much, Dr. Drumil, for being
Thank
with
you.
us. It was a wonderful talk. Thank you. Thank
Thank
you.
you. Bye. Bye. Take care. Bye.